Yeah, so I will take you through our experience in Swaziland in terms of TASP, really looking at the context of TASP within Swaziland, and also looking at the MaxART project, in which we have the MaxART implementation study, because I know that sometimes it's a little confusing. Okay. So I think we are aware of some of this data, but just to emphasize that Swaziland, being a small country and high prevalence of HIV infection, of course, because of delay, we took time to respond. We're still in denial for a long time. So our incidence kept climbing. We are currently at 2.38 new infections. And at the same time, we had a TB incidence increased. And then, however, we have done a lot in terms of responding to the epidemic through a strong national treatment program, PMTC program, and also government commitment. We've managed to at least remove procurement of all ARV drugs from any donor to government budget. So we have been looking at scaling up in this way, and we've really largely succeeded in terms of scaling up our HIV care and treatment, working with many partners, because I'm speaking as Ministry of Health, but then I'll zero into the MaxART project, which is within the Ministry of Health's National ART program. So with partners, we've been able to scale up our treatment, but as you can see in this area here shows that we are anticipating a jump in terms of the need for ART in the next coming few months, when we start estimating our need based on 500, and when we include B+ in the need for ART. So we developed the TASP framework soon after the release of the results from the HPTN 052. So we felt as a ministry we need to show some leadership here before we get overcrowded with partners who would like to participate in TASP activities. So there is a framework that we developed together with our partners just to guide what do we want as a Ministry of Health. So in our discussions, we also use this document to articulate our readiness to implement treatment as prevention as a country. So what were the principles? The principles, of course, were that we need to make sure that those who need ART, according to the eligibility criteria, are provided with the treatment as per the need. So basically just plugging in what we call the leaky cascade, because when we looked at our cascade, we realized there were some leaks. So just perfecting what we've been doing and coming up with better strategies to get people on treatment at the current guidelines. And then we also emphasize that partners assisting us in TASP implementation to come up with study protocols that will be able to provide us with evidence that we can share internationally and which we can validate in terms of the data. And so, and to also ensure a rights-based approach. So in our implementation of TASP, we have not left out, SWANEPA is the national network of people living with HIV. So we make sure that we are moving with them so that we get their opinions and they're able to go out and get opinions from the people living with HIV in the country. And to also monitor human rights, do human rights monitoring. There are 3 studies going on currently, which are related to TASP. In Swaziland, we define TASP as option B+ and immediate access to ART for all. So those are the 2 that we are defining as TASP. And so currently, we have the Safe Generations, which is under ICAP, Columbia University, which is already going on, probably in the middle or almost towards the end. Then we have the MSF. Medicines Sans Frontiers is also conducting option B+ in the Shiselweni region, and then soon they will be starting on immediate access to ART for all in that region. But I will focus on the MaxART, immediate access to ART for all, in the northern Rojo region with a catchment population of 75,000. So the MaxART project itself is really around, it has been centered around 3 keys. Key 1 and Key 2 have been going on since 2011. Key 1 is really about strengthening services to reach those in need of testing and treatment based on the current guidelines. So here we are continuing to do what we've been doing with the partners who are in the country, in which our treatment and care lead is ICAP. So we continue to do that, but we try to introduce some new innovative approaches towards getting people tested and also into treatment. And then Key 2 is a new one because it focuses on understanding the needs of the people living with HIV. So we have done a stigma, what we call a stigma index through SWANEPA, just to check how much stigma is existing in 2012. We've also started a human rights monitoring within the health facilities, just to make sure that no one feels like their rights are not being catered by the health workers. And then we also have research modeling and also qualitative studies that have been going on. In Q2, we already have done a pre-implementation study that is qualitative, that was done by the University of Amsterdam, and just giving us information about what the communities and the health workers understand about treatment as prevention, and whether they would, if they were offered the opportunity, they would take it up or not. Unfortunately, maybe I'll share next time on those findings. So we are moving to Key 3, which we hope to start this year, looking at feasibility, acceptability, and scalability and affordability of implementing immediate access to ART within MOH system. So we are not changing anything within the service delivery. With what we are doing right now in the clinics, we will continue to do it. But if we need to add anything in terms of resources, it will be strictly monitored so that in future we are able to understand what it took us to implement treatment as prevention as a country. So in terms of Key 1 and Key 2, these are the interventions focusing on males and adolescents and traditional leaders, because we realize those are the key people to get people to access or to take up services. And then we also introduced the point of care CD4s in the clinics, which we were hoping that will increase enrollment into ART soon after testing, and linkages going together. And then we've also strengthened provider-initiated testing, because we realized many people came to facilities or would attend clinics but wouldn't be offered testing. And then there's a fast-track strategy or approach that is community-based to access services or take up and demand services. Then we also have nurse-led ART initiation, which nurses in the rural clinics are able to initiate ART. This is meant to make sure that once someone is tested in that clinic, they don't have to wait for a doctor. They can be initiated in that rural area and continue treatment. Other strategies include SMS appointment reminder system, so that people come back on time for their appointments, and then improved lab services. Because we've centralized our lab services, there's a need. We have introduced a sample transport system that moves samples around. So this is just a package of some of the interventions that are going on in preparation for our study. So let me move to this one. So in Key 3, we are looking at immediate access to ART for all. And we say that epidemiological rationale for offering treatment irrespective of CD4 is clear, but we still don't understand the behavioral and operational questions around offering immediate access to ART or treatment as prevention in the country such as Swaziland. And then the proposed study is uniquely positioned to close the evidence gap by evaluating the realities of implementing the immediate access to ART for all through a government-managed health system in a high prevalence and resource-limited setting. So the combination there, you can see that government-managed health systems are usually very weak, and we are having high prevalence and resource-limited. So we just want to see how much more do you need to put in to make this a success, to make TASP a success in the country. So the specific objectives is to determine the feasibility of implementing immediate access to art, assessing outcomes and estimated impact of this approach, and affordability, and how much scalability can we see with this approach. The study design, we eventually opted for a randomized stepwise design, where we will just each site is a clinic in the rural area, and at the beginning of the month 1 of the study, all the facilities will be at the control stage. The C is for control, and then each clinic will transition to the intervention stage. So at the control stage is where the facilities will provide ART according to the guidelines that exist at that time. And then at the intervention stage is where we will remove eligibility criteria and say everybody who tests HIV positive must start ART, regardless of CD4 count, viral load, or anything else. So what we're going to analyze at the control stage, we would like to analyze, to subdivide the people into groups, group A and B, where the eligible individuals who will be enrolled on ART based on CD4 350. So we'll be looking at all the other questions that we have, but in terms of a CD4 less than 350. So if the guidelines change to 500, this will also change to 500, but we'll also indicate when did the guidelines change in our stepwise design. And then for group B, it will be non-eligible, those who have CD4 above 350. Are we going to find that these ones accept better the immediate being offered ART compared to the ones who have a higher CD4 count during the control stage? And then at the intervention stage, we'll look at still group C and D, but we'll have marked that at this stage, we have removed all eligibility, so there's no waiting for CD4 results, because we know that sometimes is a barrier to accessing treatment. So here, yes, we will immediately initiate ART, but we'll still be analyzing according to the CD4 counts, because it's not like we won't do them. We'll still have to do them in terms of monitoring, even at the beginning. But it will not be used now to determine when to initiate ART for that group at intervention stage. So the endpoints, we'll look at retention for the different groups, viral suppression. Then other endpoints include ART uptake, adherence, drug resistance, tuberculosis, and others such as cost per patient per year. The social science piece is not being left behind. It's very critical for us because we really want to understand what people are thinking. So we look at differences in implementing in the health service delivery before the implementation of the treatment for all. And then the difference also in the social, economic, and structural factors between clients who have initiated ART before and during the study. And then we are also thinking cost effectiveness, because our government is buying all the drugs. So how do we need this in future just to convince our government that this is we can be able to afford this? At what amount do we need? How much more do we need to afford in order to afford implementing this intervention? So we look at cost effectiveness and looking at value for money, per client lifetime cost, and return on investment for this approach. We will do mathematical modeling of the impact of the approach if taken to a national scale, whether how it will reduce the number of new adult infections. So basically, we haven't started because we had to change our study design because there were other studies that were going on and were taking longer than we anticipated, so we didn't want contamination. So the next steps are going to look at a sample size calculations. We had to recalculate the sample size based on the step wedge, which Teal is helping us. Still here? He's gone. From Harvard University, yes. So he's helping us with that. And then we need to finalize partnerships with Mylan for the donation of our drugs. MSF will help us with viral load testing. And then the British Columbia Center for Excellence in HIV/AIDS has offered resistance testing and then economic modeling through the Harvard School of Public Health. Then we submit to Ethics Committee and we begin our study. We'd like to acknowledge that this project has been funded through the Dutch postcode lottery. So we won a lottery. No, we didn't win it. We were just able to get the funding, a grant from the lottery. And we'd also like to acknowledge other partners we work with, because this cannot be done by only the MaxART project. Remember, we have PEPFAR, we have the UN agencies, and other local NGOs in the country. So thank you very much. This is the MaxART Consortium. Thank you.